Hello everyone, this is Dr. Madhusudan Rao on the program I teach medical students. In today's class, I am going to touch briefly on Parkinson disease and clinical presentation and its prognosis. Parkinson disease is a common neurodegenerative disorder affecting the elderly, characterized by slowness of movement. Okay, in addition to the slowness of the movement, there should be there could be one of the two symptoms, that is tremor and rigidity. Okay, there may be other symptoms like loss of smell, excessive salivation, change of mood, constipation, soft voice, sleep dysfunction, and sometimes excessive periodic limb movements experienced by some of the patient during sleep. Okay, it affects nearly 1% of the population after 60 years of age. This disease is said to be due to loss of dopaminergic neurons in substantia nigra and presence of Lewy bodies in these nerve cells. Okay. In most of the patients, this cause is not known. It is said to be idiopathic Parkinson's disease. The genetic factors play a role when the disease occurs in young patients. Okay. It has got gradual onset with regard to the tremor, which occurs on one side of the body initially. It progresses gradually and he develops rigidity and followed by slowness of movement and associated with the gait abnormalities, etc. Okay. Autonomic dysfunction in the form of excessive salivation, orthostatic hypotension, constipation, etc., they follow later. In this particular condition, history and clinical features are the main tools for diagnosis. Okay, but in doubtful cases, SPECT scan can help to make the diagnosis. So, coming to the clinical presentation, some important aspects of the clinical features of Parkinson's disease, based on which one can make the diagnosis without the help of laboratory evaluation. The tremor. Tremor is the earliest manifestation. Okay. Earlier it was described as the pill rolling tremor, but it can occur in any form. Okay. It is usually unilateral to start with. It occurs at rest. Okay. And when the patient is asked to hold some object, say if he asked to hold a book, it disappears for few minutes. Okay. But it reappears once he leaves the book and keeps his hand at rest. So, picking a book only to when he tries to pick up the book and lifts his hand, the tremor disappears. It reappears once he resumes his normal posture. That means the tremor occurs at rest. But as such, tremor is not the diagnosis, cannot make the diagnosis of Parkinson's disease based only on tremor. That is also an important point to keep it in mind. Tremor should occur at rest. It is temporarily disappears when he is asked to do some work there. That means holding a book or any object. And once he leaves that book, then keeps the hand, resumes his normal position in rest, the tremor reappears. This is the characteristic feature of the tremor in Parkinson's disease. Then other points of clinical manifestation are bradykinesia. That means patient takes longer time to complete a task. Okay, is not that rapid, that fast to complete any voluntary act. Okay, that means when you ask the patient to tap the index and thumb repeatedly, he cannot perform it so rapidly as you do it. Okay, and also stamping the foot on the floor is very slow in the patients with Parkinson's disease. So bradykinesia makes the patient to feel something is not capable of doing the voluntary act as fast as he used to do earlier. That makes the patient depressed to some extent, and that again leads to the worsening of the symptoms. Okay, so that is the reason why you have to give a lot of psychological support is needed for this patient to carry out the daily tasks. Then next point being the rigidity. The patient himself says if he is stiff, in his hand, uh, that means he is, while walking, his arm swing is slow. You can identify the patient while walking, the arm swing is slow. And when he is asked to get up from the chair without support, it is difficult for him to do so. At the same time, arm swing on the affected side is slow. And hypertonic limb, that means there is a increased tone, that is hypertonicity of the affected limb. This is tested by the degree of resistance to passive movement around a joint. That means you experience excessive resistance to passive movement. If this resistance offered is uniform, it is called lead pipe type of rigidity. Sometimes we feel the cogwheel type, where the rigidity is the resistance offered to the passive movement is interrupted by the tremor. So that gives you cogwheel type of rigidity. So these two types of rigidity or hypertonicity can be seen in the patients with Parkinson's disease. That will tell you that there is increased tone in the affected muscles. That is the rigidity or the stiffness the patient experiences with regard to hypertonicity. Then coming to the next symptom being gait disturbance. So this is very, very much incapacitating to the patient. His freedom is lost. Okay, he cannot maintain a normal stance, so he cannot walk properly. As such, gait disturbance is generally a late presentation. He is slow in walking. He starts short stepping. That means gait cycle is of short duration. There is frequent stepping and shuffling in sense is the gait is not that stable. There is festinating. There is tendency to fall. Okay, and in order to maintain the balance, patients stoop forward. Okay, when he suddenly comes across a situation that is going to be something, if it is dangerous, then he freezes. That means, for example, when he is asked to walk and he comes close to the door or door frame, he suddenly freezes. This is again a feature of gait in Parkinson's patient. These are the main features of Parkinson's disease, that is motor features, say tremor, say the bradykinesia, say the stiffness, say the gait disturbances. These are all motor symptoms. Coming to the non-motor symptoms, there is a change in the voice becomes soft, and difficulty in swallowing. There is postural hypotension. He feels giddy when he suddenly gets up from lying posture. There is memory loss and cognitive impairment. And the patient goes into depression. Okay. And there could be autonomic dysfunction in the form of salivation, constipation, urinary retention, and erectile dysfunction. The autonomic dysfunction, they do not respond to your medical management, medical treatment. This point has to be remembered. Coming to the evaluation, most of the time, this is one of the clinical situations or the disease that can be diagnosed based on history and clinical examination. Whereas laboratory evaluation is going to help little in this particular condition. So MRI imaging is done to eliminate only other conditions like normal pressure hydrocephalus, which also occurs in the old age, and patients develop gait disturbance, cognitive impairments, in addition to urinary incontinence. And also certain conditions like with subcortical silent infarct. Subcortical means in the subcortical deep structures are the basal ganglia. So infarcts involving the basal ganglion again mimic the features of Parkinson disease. When they are present, it is the feature of the multiple silent infarcts, not the Parkinson disease as such. And ultimately, response to levodopa is diagnostic. When you give small doses of levodopa to these patients with Parkinson disease, suspected Parkinson disease, if there is a response within a week or 10 days, that is diagnostic. But symptoms in these patients reappear once again once you, even despite the fact you continue the treatment, after an initial response, the symptoms reappear. And then that scan is going to test the dopaminergic uptake. This is again a diagnostic test performed in doubtful cases. Well, coming to the treatment, a brief note in the treatment, not going to give the detailed account of it. The medical therapy, physiotherapy, and surgery. Mainstay of treatment for medical management is the levodopa. That is levodopa and carbidopa combined together. Other dopaminergic drugs are available like pramipixole, other things which are not going to give you full details because that covers a big topic on the Parkinson disease. But as such, when you use the dopaminergic drugs, the response is good for a period of 3 to 6 years. This is followed by resistance and rapid deterioration. These drugs, the problem of these drugs is they have on and off motor effects associated with side effects. Tolerance develops with poor response. But by and large, treat the young patients aggressively. Okay? Then followed by physiotherapy. So give the programmed exercises to limit the fatiguability. Then music therapy and cycling is going to give better improvement in the patient with the Parkinson disease. You see the patient who is not able to walk properly is able to dance to the tune of the music. That's the wonderful effect of the music therapy in the patients with Parkinson disease. And surgery nowadays has become the mainstay treatment for these patients when there is no proper response and the tolerance develops to the drugs. And over a period of 5 to 6 years, when the response is getting poor and poor, and deep brain stimulation is going to be effective in most of these patients. Okay, and DBS has become the primary treatment for many of the patients with Parkinson disease nowadays. An important note on the prognosis. This is the idea of putting this slide in this particular lecture. Patients presenting with gait disturbance and posture abnormalities, they have poor prognosis. Okay. Number two, older patients with cognitive deficiency who do not respond to medical therapy also have poor prognosis and they deteriorate rapidly. Okay. And at the same time, older patients presenting with hypokinesia and rigidity, they also progress very rapidly. Okay. And lastly, patients who present with tremor as initial complaint, they have long benign course, but they do deteriorate over time. Okay. But they have the long benign course. These are the patients who needs aggressive treatment. Yes. So thank you very much for patient listening. We'll meet you again in the next class. Until that time, this is Dr. Madhusudan Rao. Bye bye and see you later.